My dear students, Dr. Ashfaq over here, and as you are well aware, I have authored books for neetpg, neetdm, neetmch, as well as some of the books for USMLE examinations, MRCP examinations, and my lectures would be intended to get you right on the top there for your next examinations, DM examinations, MCH examinations, MRCS, MRCP, USMLE examinations. I hope my videos will benefit you a lot. I will be presenting my things in a very easy, simple and palatable form for you. Wish you good luck for your exams. Thanks a lot. Today we would be taking up a topic, and that would be an important intra-abdominal organ, and we would be discussing stomach today. As far as the stomach is concerned, we will be dealing with the surgical anatomy of the stomach. We will be dealing with the relations and the blood supply of the stomach, all the other associated applied aspects and the medical and important surgical conditions related to the stomach. As far as the surgical anatomy of stomach is concerned, first of all you have to remember that the stomach forms the most distensible part of the gastrointestinal tract, and it is also given the name as gaster, resembling something like a sac. So that is one important point about the stomach. Then what quadrants of the abdomen does it occupy? We have already done with the quadrants of the abdomen, and you have to remember that the major part of the stomach lies within the epigastric area, the umbilical area, and the left hypochondric area. Now, as far as the shape of the stomach is concerned, the shape of the stomach can be pretty variable depending upon the amount of food it contains. Normally we can say that the stomach is J-shaped, and it can vary its shape as far as the build of a person is concerned. The asthenic and obese people, they can be having different types of stomach. So we'll not go much into that, but we will be dealing later on with the radiographic aspects of stomach, which is more important. Now, as far as the capacity of the stomach is concerned, in case of newborn, the capacity may range between the 30 ml to 50 ml, and in case of an adult, the stomach can take up to almost 1.5 to 2.5 liters of food within it. So the capacity is highly variable. Now, as far as the stomach is concerned, you have to remember that the stomach has got two orifices. One is the proximal orifice and another is the distal orifice. And over here, this is the cardiac orifice and this is the pyloric orifice. Now, first of all, the cardiac orifice lies at the level of T11, the thoracic 11 vertebra, and the pylorus or the pyloric end lies at the level of L1 vertebra. So in here there passes a plane which we give the name as transpyloric plane, which is anatomically and surgically significant. We'll deal with that at a later aspect, but over here you have to remember the cardiac orifice and the pyloric orifice. The cardiac orifice or the proximal orifice happens to be more of a physiological sphincter which prevents the reflux of acid from the stomach into the esophagus. And over here, this is both a physiological as well as an anatomical sphincter, because there's an underlying pyloric muscle over here and it gives it the anatomical presence over there. So we can well feel, once we take the specimen of the stomach, we can well feel the pyloric end of the stomach, whereas we will not be able to feel for the cardiac end that efficiently. So over here, this is both an anatomical and a physiological sphincter, and over here, this is just a physiological sphincter over here. So that's important. Now, the parts of the stomach, as you can see over here, this part is the fundus of the stomach, and this is the body of the stomach, and this is the pyloric antrum. And the pyloric antrum then here narrows into something which we give the name as pyloric canal. The pyloric antrum is almost 7.5 centimeters in length, and the pyloric canal is just narrows. It is just 2.5 centimeters in length. So the fundus, which is normally occupied by the gas, it is not normally filled with food, because it is normally filled with air. It can only be once the stomach is fully distended with food, only then we can have the fundus fully involved. Now over here, the body, the pyloric antrum and the pylorus, they are the other parts other than the fundus of the stomach. So this is something about the stomach. Now we have got two orifices, one over here and one other here, which we already studied, and two curvatures, and this is the lesser curvature and this is the greater curvature, and two surfaces, one which faces you is the anterior surface, and the one which faces posteriorly is the posterior surface. So this is the lesser curvature and this is the greater curvature. And why is this lesser and greater curvature important? Because there is the peritoneal folds which are attached to the stomach, and the peritoneal folds attached to the stomach are specifically given the name as omentum. And we have the lesser omentum just taking its attachment from the lesser curvature of the stomach, and the greater omentum just taking its origin from the greater curvature of the stomach and going down. The greater omentum is also called as the abdominal policeman, and we will deal with the greater omentum and the lesser omentum more in detail once we discuss the omenta and the peritoneum. But over here you have to remember that the lesser curvature gives attachment to lesser omentum, and it is attached from the lesser curvature of the stomach to the porta hepatis of the liver, which is the hilum of the liver. So that's important. Now, as far as the stomach is concerned, we have to know important the posterior relations of the stomach. The posterior relations of the stomach are sometimes asked by the examiners because they form the stomach bed. We have got certain important beds important in the anatomy, and one of the beds is the tonsillar bed, and second is the stomach bed, in addition to some other beds. So over here you have to remember that the stomach rests on what important structures, as you can see over here. This is the left kidney. So the left kidney, because the stomach occupies the left side, we have the left kidney as a relation to it. Now then, on top of the kidney, we have the suprarenal or the adrenal gland. So the left kidney and the left adrenal form two important posterior relations of the kidney. In addition to this, you have the organ which is the spleen over here, and the splenic artery as well. Now important, the transverse colon along with the peritoneal attachment, which we give the name as transverse mesocolon, that also forms an important posterior relation. And the splenic flexure of colon, which is a bit avascular part of the colon, it also lies in relation to the stomach. And the spleen from the hilum of spleen exits this, enters this artery, which is a tortuous artery, is a splenic artery, and the splenic vein exits from it. The splenic artery forms a direct posterior relation of the stomach, or these are the structures which constitute the stomach bed. Very important from an academic viewpoint. Now, as far as the blood supply of the stomach is concerned, stomach is a highly vascular organ, and the stomach has got four important vessels supplying it. As again we go to the curvatures, this is the lesser curvature of the stomach, and this is the greater curvature of the stomach. In the lesser curvature of the stomach, you can see over here, this is the left gastric artery. This left gastric artery is a direct branch of celiac trunk, and celiac trunk is the first ventral branch of abdominal aorta. So the left gastric artery gives branches over here. So this is the first vessel which supplies the upper part of the lesser curvature of the stomach. In here you have this vessel which is the hepatic artery, and the hepatic artery gives this branch. This is the right gastric artery. So along the lesser curvature you have the left gastric artery and you have the right gastric artery. The left gastric artery being a branch of directly from the celiac trunk, and the right gastric artery being a branch of the hepatic artery. And this is the greater curvature, and this is the greater curvature. This is the right gastroepiploic artery, and this is the left gastroepiploic artery. The left gastroepiploic artery is a branch of splenic artery. Splenic artery gives the left gastroepiploic artery, and this right gastric artery is a branch of gastroduodenal artery. So you have to remember which vessels, and they happen to be branches of which vessel. So that's important. So four vessels, as we have studied over here, they form an important part of vascular supply of the stomach. So you can well appreciate in the lesser omentum we have the left gastric artery and the right gastric artery and the anastomosis of the two vessels, and along the greater omentum we have the right gastroepiploic and the left gastroepiploic vessels and the anastomosis around them. So whilst the surgeon is just operating upon the stomach and along the lesser and the greater curvature, he has to be well aware of these facts of these vessels. He cannot inadvertently cut these vessels, so that's important. Now, the veins, they almost follow the same pattern, and one important thing you have to remember that at the pylorus over here, at the pylorus, there is a vein which lies in front of the pylorus, and that is given the name as prepyloric vein. It is significant. You recognize the pyloric end of the stomach by the presence of a vein which lies superficial to the pylorus, and that is given the name as prepyloric vein of Mayo. So that's important. The rest of the vascular supply corresponds to the to the blood supply, the venous drainage corresponds to, you can have the right gastroepiploic vein, the left gastroepiploic vein, the right gastric vein, and the left gastric vein, and this is the portal vein over here. But you have to remember about the pre-pyloric vein of Mayo. That's important, sometimes asked by the examiners from an academic viewpoint. Now, as far as the lymphatics are concerned, you have to remember that the stomach is divided. The stomach is divided into 3 lymphatic territories, 1 lymphatic territory to the right side and 2 lymphatic territories to the left side. The left side we divide into upper 1/3 and lower 2/3. Could you just minimize this figure, please? Yeah. So we have got this segment on the right side denoted by area B. This is the area A and area C. This upper 1/3 and this is the lower 2/3 on the left side. As you can appreciate over here, the upper 1/3 of the left side that drains into the pancreatico-splenic group of lymph nodes, and this is the area which corresponds to the right gastroepiploic artery, and here we have the right gastroepiploic lymph nodes, and over here these are the subpyloric group of lymph nodes just below the pylorus, and over here we have the celiac trunk, and surrounding the celiac trunk we have the celiac group of lymph nodes, and this is the hepatic group of lymph nodes, and this is the group of lymph nodes along the left gastric vessel, which we give the name as left gastric lymph nodes. So you divide the stomach into 2 predominant lymphatic territories, the right one and the left one, and the left one is further divided into upper 1/3 and lower 2/3. So the pancreatico-splenic group of lymph nodes, the right gastroepiploic group of lymph nodes, the subpyloric group of lymph nodes, the hepatic, the celiac, and the left gastric group of lymph nodes, they just drain the stomach. And it is important, the lymphatic drainage of stomach is important from the perspective of gastric cancer, because we can just assess the stage of the cancer by the involvement of the lymph nodes, and in gastrectomy we also just do the excision of these lymph nodes as well. And gastric cancer
Battery done.
Predominant certain populations over there with this concept of the lymphatic supply and the lymphatic involvement of the gastric cancer is important. So this is something about the lymphatic drainage of the stomach, and a question quite frequently asked as a short note as well. Now, in addition to this, we have the nerve supply. Basically, you have to remember that with the autonomic nervous system supplies the stomach, and you have got the sympathetic as well as the parasympathetic system supplying the stomach. And as far as the sympathetic system is concerned, the thoracic 6 to thoracic 10, T6 to T10 nerves supply the sympathetic nerve supply to the stomach. And the predominant source of parasympathetic nerve supply to the stomach is the vagus, the 10th cranial nerve. Now basically vagus is vague nerve because basically a cranial nerve, but it goes down to the abdomen, and that's it's given the name as vagus because it's very vague. Basically it should have been restricted, it goes to the cranial part, but over here it goes just down to the abdomen and supplies even up to the stomach. So this is important. The vagus, the right and the left vagus supply the stomach, and the vagus is the parasympathetic to the stomach, and it is secretomotor. What's important from this perspective is that secretomotor, the secretion of acid of the stomach, occurs as a result of activation of the parasympathetic system or the vagus, and the contraction, the motor contractility of the stomach is because of the vagus. Now, why is it important? I will be coming to that. So first of all, you have to remember that the left vagus comes, it is given the name as anterior vagus, and the right vagus comes mostly posteriorly, and it is given the name as posterior vagus. So the left vagus and the right vagus supply the stomach, and it supplies the parasympathetic component to the stomach, and it is secretomotor to the stomach. Now, what's important is that there are many questions from an academic viewpoint asked by examiners. The first of all is sometimes they ask, what is nerve of Grassi? So nerve of Grassi, or criminal nerve of Grassi, is a branch of the right vagus. The branch of the right vagus which supplies the fundus of the stomach. So the criminal nerve of Grassi is a branch of the right vagus or the posterior vagus which supplies the fundus of the stomach, secretomotor to the specifically to the fundus of the stomach. And then we have the nerve of Laterjet. The nerve of Laterjet, this nerve of Laterjet, it is also a branch of the right vagus, which is also given the name as posterior vagus, and it supplies the pylorus of the stomach. This you can see over here, well demonstrated over here, nerve of Lattiger supplying the pylorus specifically. So that is one thing. The third thing sometimes asked is, what is crow's feet appears of the nerves at the stomach. So what is crow's feet is that we have got the branches of the vagus. We have got the branches of the vagus we supply over here, and the branches are the hepatic branches, the gastric branches, and the pyloric branches, and they just form appearance just like the feet of the crow, and that is given the name as crow's feet. So this is from an academic viewpoint. Now what is important, because previously once we did not, people used to have ulceration as a result of increased secretion of the acid or increased acid output. What they used to do, we did not have those types of drugs which we use currently, the H2 blockers, ranitidine, famotidine, nizatidine, roxatidine, loxatidine, or the proton pump inhibitors like omeprazole, rabeprazole, dexarabeprazole, ensoprazole, lansoprazole. And previously they used to depend upon surgeries for recurrent ulceration, for serious ulceration, because vagus is secretomotor. That means they used to cut the vagus, and that surgery was called as vagotomy. Now vagotomy had types. It could have been truncal vagotomy, a very obsolete procedure. They used to cut the main trunk of the vagus, and that was quite not, I mean to say, specific or scientifically not that good. Then came the advent that they did subsegmental vagotomy, and the procedure just came down. They sectioned the particular branches of the vagus, selective vagotomy, and then the highly selective vagotomy, that they used to cut or surgically remove those branches which supplied the particular areas. So that is the advent went from vagotomy, truncal vagotomy, to selective vagotomy, to highly selective vagotomy. Now what is the problem? Because vagus is secretomotor, fine. By doing vagotomy, they used to cut the secretory function of the organ. But what about the motor activity? So they would also just decrease the contractile activity of the stomach as well, the motor activity of the stomach, as a result of which there could be gastric stasis. There would be the accumulation of food within the stomach. So they had to combine this procedure with something which we call as pyloroplasty. What they used to do, they used to cut this part of the stomach, remove the pyloric, and used to ensure a drainage procedure, while in the stomach would not be having gastric. So they used to do a procedure which would facilitate the gravitation of food down, and that procedure was called as pyloroplasty. So vagotomy was to be combined with pyloroplasty. So that is something about the nerve supply of the stomach, which is very important, had clinical implications more previously. Now, as far as the stomach is concerned, I was telling you previously, this is the lesser omentum. So this is the lesser omentum, and over here you can see that from the lesser curvature, it just goes in relation to the porta hepatis. Now this lesser omentum has got two parts. Number one is the part which connects the porta hepatis directly to the stomach, and that part is given the name as hepatogastric ligament. And then there is another part of the lesser omentum which just attaches the porta hepatis to the first part of the duodenum. So lesser omentum has got two parts, the hepatogastric part and the hepatoduodenal part. The former connecting the porta hepatis to the stomach, and the second part connecting the liver to the first part of duodenum. So that is it. And here, over here, we have the greater omentum, a big fold of peritoneum from the greater curvature of the stomach towards the transverse colon. And you can see over here, we have got lymphatic aggregations, a lot of fat over here. So greater omentum is characterized by the fact that it has got a large amount of fat as well as immune function. And once there is any infection around, the greater omentum moves towards the source of infection. That's why it is given the name as abdominal policeman, and it has got a role of moving towards the organ or moving towards the source of infection. So that is the function of greater omentum over here. Now, this is sometimes asked from an academic viewpoint, what's Traube space? So Traube space, you can see over here. Specifically, this is the Traube space. And what is the Traube space over here? You can see Traube space. And in here, this is the inferior margin of the left lobe of liver, to be specific. This is the left subcostal margin, and this is the inferior margin of the left lung, and this is the anterior border of the spleen, and this area is given the name as TROPS area. Why TROPS area is important? Because normally it is resonant, and in case we have got a full stomach, it gets obliterated, and in case there is splenomegaly, this area can obliterate, and in case there is pleural effusion, this area can get obliterated. So it is an important area for a physician, wherein the percussion notes may change as far as the normal anatomy is concerned, or in case of pathological conditions, the TROPS area will be obliterated. The dullness in the TROPS area will be different. So that is the significance of TROPS area. You have to remember this. Now, we were mentioning something about the pylorus. And over here, this is the pyloric end. And sometimes what can happen in a newborn, we can have a hypertrophy of the pyloric muscle, a condition called as congenital hypertrophic pyloric stenosis. The pyloric muscle undergoes hypertrophy. So this is the congenital as a result of which you can have a gastric outlet obstruction, and there will be vomiting of anything which a child takes back, and this is called as congenital hypertrophic pyloric stenosis. It can occur in adults as well, a condition different from the congenital hypertrophic pyloric stenosis, acquired pyloric stenosis. So that is the significance of pyloric muscle over here. Now, as I told you initially, the shape of the stomach. The shape of the stomach, we just do a radiographic procedure called as barium meal. Barium swallow is done for esophagus, barium meal is done for stomach, barium enema is done for the gut. And over here you can see this is how a stomach looks on a radiograph. Normally, because the black is ear, so in radiograph we have black represents the ear. So because this is the fundus of the stomach, this is filled with air, and you can see the curvature, the greater curvature of the stomach, the lesser curvature of the stomach. This is the area of the pylorus, and this is the area of the duodenal cap, so which will be dealing ahead. So this is how radiologically this is the esophagus, and you can appreciate narrowing over here. So this is the greater curvature of the stomach, this is the lesser curvature of the stomach, and this is how the stomach looks on barium meal. Exactly J-shaped, as I mentioned in the initial part of my lecture. Now, stomach is important in addition to the duodenum because sometimes we can have chronic ulcerations in the area of the stomach, and two areas, peptic ulcers are common within the stomach, and peptic ulcers are common within the duodenum. So you have a stomach ulcer over here, and you have a duodenal ulcer over here. So this is important. Now, the interior of the stomach has got mucosal folds, which are given the name as rugae. And in certain cases, in certain disease conditions, you can have much exaggeration of these folds, a disease called as Meniere's disease. So you can well appreciate over here the mucosal folds are highly exaggerated. So this is associated with protein losing enteropathy, a thing which we'll deal in medicine. But over here you have to remember that the interior of the mucus of the stomach has got mucosal folds, well defined, but not as hypertrophied as this. So this is a gross hypertrophy of the interior of the mucus of the stomach, and this condition is called as Meniere's disease. So this is something which we had to know about the stomach. The stomach happens to be asked in your examinations, and it is very important for a gastrosurgeon, GI surgeon, to know all these facts about the stomach. There are many other conditions affecting the stomach. I mean to say cancers, gastric cancers of stomach, and we will be dealing with those in pathology. Hopefully I find that this important class would benefit you a lot, and you will just go and revise these points well. Thanks a lot.